Hello, this is my PowerPoint over the mental health changes in the older adult. Mental health is no different in the geriatric population, but different life events, challenges, and transitions in life increase the prevalence of mental health disorders as noted by Tui and Jett in their 2018 textbook named Gerontological Nursing and Healthy Aging. In the 2017 WHO article called Mental Health of Older Adults, the prevalence of stressors rises with things like loss, reduced functional ability, and mobility, and other chronic health problems that impact coping. Likewise, retirement, the loss of spouse, friends, freedom, and mobility all add to feelings of isolation. From the same WHO article, we know that mental health has an immense impact on physical health. Because older adults are more likely to suffer from severe chronic health problems, managing these problems can also lead to bad coping. Tui and Jett note that mental health problems are viewed as a normal consequence of aging or dementia by society oftentimes. A lack in financial resources leads this population away from seeking help for mental health concerns. Depression is not a normal part of aging, but is very prevalent in this population. Geriatric depression doesn't always meet the full criteria of major depression, so we classify it as subsyndromal depression, noted by Kronz's 2018 article, Geriatric Depression. As described in the 2018 Kronz article, low levels of serotonin, norepinephrine, and other neurotransmitters can cause brain changes contributing to depression, especially when coupled with family history or trauma. In the NIH article titled Depression in Older Adults from 2022, we see that there are many different types of depression. Major depressive disorder lasts longer than 2 weeks and interferes with the ability to perform ADLs, while the persistent depressive disorder lasts longer than 2 years, but the individual can still perform their activities of daily living. There's also depression related to substance abuse or induced by severe medical illnesses. Specific to the older adult population described in the 2022 NIH article, isolation and loneliness are the strongest factors leading to developing depression. Now, let's look at the depressed brain right here. This scan shows that there's far less activity while performing activities of daily living. We can see that all of the brain activity right here. In a normal brain, the entire brain would be lit up, but due to the geriatric depression, this is obviously lessened to a great scale. The Geriatric Depression Scale is a self-report scale with yes or no questions that allows for cognitively intact people to determine the level of risk for depression they have, noted by Tui and Jett in the previously mentioned book from 2018. In that textbook, healthcare professionals must ask direct questions to assess suicidal ideation, thoughts, plans, and access to methods. Other important questions are related to elder abuse, poor environment, and changes in patient roles after the death of a partner or disability. These are very necessary to ask. In the 2018 Tui and Jett textbook, we see that psychiatric and medical histories allow for noting recent changes in mood, mental status, and isolation. A physical exam focusing on neurological function and cognition shows possible flat affect and inconsistent memory loss. Tui and Jett's textbook also mentions the importance of conducting a medication review to see if any medications are causing symptoms, similar to those of psychiatric symptoms. TSH, vitamin D, folate, and CBC lab values allow providers to rule out other causes of depressive symptoms. Depression management is always patient-centered. Presented by the Tui and Jett 2018 textbook, cognitive behavioral therapy and second-generation antidepressants are often used in combination to manage depression in the older adult. The most common antidepressant used in this population are SSRIs, or selective serotonin reuptake inhibitors, which are tolerated well in older populations and have far less side effects. Electroconvulsive therapy is a safe and great alternative for older people who are not responding to treatment and need immediate symptom relief. Non-pharmacological therapies can be implemented in addition to other treatment options, or can be used as the sole treatment to allow for a greater sense of autonomy, which in turn increases treatment adherence. Alcoholism and alcohol abuse is the third most prevalent psychiatric disorder in older adults and is widely underdiagnosed and often goes unrecognized in this population, as described in the Tui and Jett textbook about gerontology. It is important to note that both genders are at high risk for effects of alcoholism. The Tui and Jett textbook notes consequences of alcohol abuse, including cirrhosis of the liver, cancer, heart failure, dementia, delirium, urinary incontinence, gait disturbances, depression, unexplained falls and injuries, and suicide. Tui and Jett implement the American Geriatric Guidelines to define at-risk drinking as someone that consumes 2 or more drinks a day, and greater than 5 drinks on one occasion is described as binge drinking. Alcoholism is hard to diagnose in older people because of psychosocial and functional declines that could be viewed as merely getting older. Therefore, it is important to be vigilant and open to all possibilities and diagnoses when patients come in for visits. Now, as we see here, this is an alcoholism brain. We see that there are a lot of areas of the brain that are black, meaning they are not active when performing activities of daily living, whereas a normal person's brain, all of these functions would be lit up. Using the SMAST-G assessment that has 10 yes or no questions indicates an alcohol problem if 2 or more are answered positively. From Tui and Jett, in their textbook, we ask questions like, do you underestimate how much you drink? Do you skip meals because of drinking? Do you think that you drink to decrease shakiness and tremors? Do you drink to relax or take your mind off your problems? And does drinking help you when you feel lonely? We should also be paying attention to verbal and nonverbal cues for alcoholism, as these common signs and symptoms can often be overlooked and confused with other medical diagnoses. These signs and symptoms include irritability, unexplained falls or injuries, chronic pain, incontinence, and mood swings. Due to the vulnerable nature of assessing for such a stigmatized disease, we as healthcare professionals must create a safe space and employ therapeutic communication to ensure a trusting, therapeutic nurse-patient relationship. Our treatment for alcohol abuse in older adults always is focused on a holistic approach to care. Obviously, full abstinence is the goal, but educating the patient on effects of alcohol, ways to reduce intake, and other things of that sort can help in displaying in the Tui and Jett 2018 textbook. Likewise, the goal of brief intervention is to reduce alcohol consumption, which focuses on introducing formalized intervention and is able to gauge readiness for change. In a similar manner, long-term self-help programs are often more common and are more successful. These include Alcoholics Anonymous and other support groups. The Geriatric textbook by Tui and Jett in 2018 describes the danger of a phenomenon called acute alcohol withdrawal, which is common among older adults that have significant physical dependence. This can often be causing a medical emergency and be necessitating a hospital admission to detox. This is even more common and severe in symptoms and in length of symptoms in older adults. The delirium tremens raise the risk of mortality from respiratory failure and cardiac dysrhythmias. Treatment is usually benzodiazepines. Assessing the mental status, vital signs, fluid and electrolyte imbalances, and lowering environmental stimuli is very important. Educating the patient and family on signs and symptoms of distress, mental health distress specifically, is important, and providing easy-to-use educational materials to older adults as a concept outlined in the Tui and Jett textbook. Educating the patient on non-pharmacological anxiety management through progressive relaxation exercises, deep breathing, and meditation is also noted in the Tui and Jett 2018 textbook. Instead of focusing on complete abstinence and alcoholism as we previously described, the textbook talks about educating patients on the risk versus benefits of alcohol consumption and stressing ways to reduce consumption and referrals to community resources. Social isolation is a huge cause of depression and anxiety in the older adults, so implementing community groups, elder hangouts, and encouraging family visits are all important. During the aging process, many people lose lots of physical abilities and immobility because of chronic medical conditions, so maximizing the older adult abilities and exercising increases physical independence and a sense of self-worth overall. Now for our case study. John is a 75-year-old white male who has just lost his wife 2 months ago due to a 10-year battle with Alzheimer's disease. He himself was diagnosed with stage 4 brain cancer just 2 weeks ago. His 45-year-old daughter brings John into the mental health clinic because she's worried about his flat affect, lack of personal hygiene in the past 4 days, not participating in retirement community activities, and explaining, "I just want to be with my wife again." So what do you think medically would we be dealing with in terms of a mental health diagnosis? Well, we know that John has the following risk factors for depression: being an older white male, recently losing his spouse, and diagnosed with a terminal disease. Some signs and symptoms that can help us confirm the diagnosis of depression include the lack of interest in socialization, poor hygiene, flat affect, and expressing feelings of suicidal ideation when he wants to be with his wife that had recently passed. Our biggest nursing diagnosis for John is going to be related to the risk for suicide. The risk for suicide is going to be our biggest concern because he's a high-risk patient for suicide, and given the heightened risk for suicide in the geriatric population altogether by Tui and Jett in their 2018 textbook, Gerontological Nursing in Healthy Aging. Our plan of care for John is going to be determining the mental status of the patient. We're going to assess how high of a risk he is for suicide. Then we are also going to be referring John to support groups and a therapist. The therapist could initiate medication regimen like SSRIs and other form of cognitive behavioral therapy in treating John's depression. And these are my references materials that I gathered for my presentation. Thanks so much for watching.